I want to welcome commissioners and members of the public. This meeting is another remote-only commission meeting. This meeting is permitted under the commission statute, which talks about members being present and voting. There's no restriction limiting presence to being present.
Commissioner Pollack, we can barely hear you.
How about now?
Still very faint.
All right. Can somebody send me a call-in number? I will mute the computer here to call in on the phone.
Actually, we could hear you extremely well right then.
Okay. I'm not sure what's going on. I have I'm in a room with microphones all around it, and I can't really move. Is this better?
Yes, that's fine. Yes.
All right. I'm going to start over from the beginning then. I want to welcome commissioners and members of the public. This meeting is another remote-only commission meeting. This meeting is permitted under the commission statute, which talks about members present and voting. There's no restriction limiting presence to being present in the room. Present remotely is being present, and it's something the commission's done on a more limited basis for a long time. Given that this is a remote-only meeting, some additional ground rules will apply. I'm going to begin the meeting with a roll call of commissioners. During the meeting, it's important that people speaking identify themselves before speaking. That way, commissioners and members of the public will know who's talking and have the same knowledge as if the meeting were being held at our office building. All commissioners are unmuted and they speak. Public and staff are in listen-only mode. I could ask that commissioners mute themselves when they're not speaking. It'll help with the volume and it'll help with the background noise.
Can you hear now?
I can hear you, Ben. Due to the possibility of background noise, please mute your phones when not speaking. For this meeting and future remote-only meetings,
why don't
those documents
sort of
that'll be acted on and discussed
let's try to get back in. Okay.
So that members of the public will have time to download them before the meeting begins. We will continue to provide advance notice of how to dial into the meeting by posting that information on the commission website, homepage, and on our various social media challenges. I'll now call the roll. Commissioner Boyle.
So Commissioner Boyle has been trying to dial in Levon, and she can't. She was on, she got dropped off, and now she can't get back on.
I need to know how she's trying to connect, Ben. I don't know. I mean, she would have to call or call maybe Vincent, and he could walk her through it at this time.
So are you dialing in on
how she's trying to actually connect?
Or are you coming through your computer speakers?
We're getting the background music.
Yeah, just dial in. Just try to dial in. Okay.
All right. We'll let her dial in and we'll come back to her. Commissioner Bandari, I heard before. Commissioner
Yes,
Hammerschlag,
I'm here.
Yeah, Commissioner Hammerschlag, I heard before also. Commissioner
Yep,
Metz.
I'm here.
Commissioner Metz, I heard before. Commissioner O'Connor. Jim, are you there? I don't hear Commissioner O'Connor.
Motion to check your bell.
Levon, is Commissioner O'Connor muted or?
Yes, no, I just unmuted him. He must have reconnected. He's there.
All right. Commissioner O'Connor, can you hear us?
I can hear you. Can you hear me?
Yes, very good. Thank you. Commissioner O'Grady.
No, I'm not seeing him online.
Okay. Commissioner Reimer.
Reimer is online.
Commissioner Reimer.
Checking.
Commissioner Reimer, are you trying to speak?
Yes, she's there. I got it.
Her.
Got her.
Yes.
But we can't, I have not heard her yet.
She's unmuted and just self-muted.
we'll need to work on that one, because she needs to be able to talk. Lots of background music from somebody. All right. Whoever's got the background music, if they could mute. There we go. Commissioner Sargent. Randy? There, good. Commissioner Thomas? Stephen, are you there?
Yeah, I'm here. I thought that music was coming from you. We forgot to turn this off.
It was not mine. Commissioner Wang?
Yes, he is.
Marcus?
Yes, he is here. And yes, there he goes.
Marcus,
Can you hear me?
Yep, there you
Yep,
go.
Commissioner Wang's right here.
So the only two that we haven't made contact with who are on the line are Boyle and Reimer.
Mr. Chairman, this is Commissioner Dorden. I hope you can hear me this time.
I can hear you loud and clear, Chip. Thank you. And we missed you. You weren't on the list here, so thank you for speaking up.
This is
Okay,
Commissioner Boyer.
I got on before you did.
Yeah, see, I got you.
Roger.
You were on the
Commissioner
list.
Boyle, are you on?
That was Commissioner Boyer who said she was on.
Boyer, but Boyle is still, we still have not heard from. B-O-Y-L-E. Or Commissioner Reimer. Okay. So I have 12 commissioners that I have at least mentioned. That means there's one that I'm not. Is there anybody else on the line who hasn't mentioned, hasn't spoke? Okay, so we're still. Then what's with Commissioner Boyle and Commissioner Reimer? Can they hear us?
Yes,
Commissioner,
Reimer is on, yes.
I know she's on, but I don't know. I haven't confirmed that she can hear us, or I can't hear her.
I'm actually looking to make sure to see. Yeah, she's connected. I'm not seeing the audio right now, so I'll try to help her to get up. There she goes. She's there now. Commissioner Reimer is there.
Commissioner Reimer, can you hear us? We can't hear her.
Okay.
She's
Yeah,
not
she just texted me that she can hear. Yes, she can hear us. Now I'm
we
just
can
trying
hear her.
to we can hear her.
All right. So can we make sure that she has a way, Ben, to contact you if there's if she needs to say something?
yes, I will email her.
All right, Commissioner Reimer, we're going to email you so that you can at least connect to Ben if you can't. And also we can email her some instructions, maybe to call in on a landline so that she can speak that way.
Yeah, I'm doing that now as well.
All right. But what about Commissioner Boyle?
I'm getting her the dial-in information too.
All right. While we're waiting for the others two to come online completely, do any of the commissioners have any questions about the procedure for today's meeting? Hearing none, I think we can get started with approval of the minutes.
Commissioner, I actually have an email that Commissioner McCarthy is on the line. He must be dialed in, so I'll check to see if we can start hearing him. And I'm getting the information to the other two.
Okay.
Yes, Commissioner McCarthy says, I'm also online.
Okay, good. So maybe we can at least get them to approve the minutes with electronically like that. So included in your packets are copies of the minutes from 2 sets of commission meetings, which include the March commission meeting and the special April commission meeting, which took place by public teleconference. Approval of minutes for each meeting will need a separate motion and vote. And I will do this beginning with the March public meeting that took place by teleconference. Do I have a motion to approve the March 19th minutes?
So moved. Commissioner O'Connor.
Who's speaking?
Commissioner O'Connor, so moved.
Mr. O'Connor moves. Do I have a second?
Second, Boyer.
Mr. Boyer, second. All in favor?
Aye.
Aye. Aye. Aye.
Any opposed? Hearing none, I'll entertain a motion to approve the minutes of the April 3rd public meeting that took place by teleconference. Do I have a motion to
So
approve
moved.
those? Who
So
spoke?
moved.
Gordon? Second?
Second O'Connor.
Second O'Connor. All in favor?
Aye.
Aye.
Opposed? The ayes have it. All right. Update of activities. Before we begin with the formal update of activities, I'd like to go off the agenda and ask Commissioner Thomas if he would be willing to provide us with a brief update of his activities working with the Governor's Task Force to address the disparities currently being encountered in the burden of disease associated with COVID and the treatment associated with COVID. Commissioner Thomas, would you be willing to speak for a couple minutes on what you've been doing in that area? Commissioner Thomas? Unfortunately, I can't hear Commissioner Thomas. Is he muted?
No, he dropped off for some reason. I'm not seeing him anymore. I'll let you know when he's back.
We'll come back to that then.
So, Levon, Commissioner O'Grady said he got thrown off. Can someone send the audio dial in?
I just sent it to Dee to please try to send out to all the commissioners that may be having a problem.
And Commissioner McCarthy says his line is muted. Commissioner McCarthy should have his line unmuted.
I'm not seeing any audio information for Commissioner McCarthy, so I can't unmute him.
If he's calling in, we'll need to know the phone number he's calling from, probably to be able to unmute him.
I see his name, there's no audio. Okay, I'll keep working on it.
All right, is Commissioner Thomas back on the line yet, or no? So, Levon, I'll ask you to tell me when Commissioner Thomas gets back on the line, please.
So Commissioner Thomas says, I can hear, but for some reason I can't be heard.
Again, I think he dropped off and he hasn't put in the audio stuff yet, so I can see his name, but there's no audio link to us right now.
Can you give me the audio?
I can't because each individual has a different audio pin. Only thing I can do is send it directly to them.
So, Commissioner Thomas, you have to click the button that says connect to audio, the computer audio. All right, Ben, do you want to go ahead with introduction of the new employee?
Sure.
Go ahead.
So I want to thank all the commissioners for attending today. We have the opportunity to introduce a new staff member in the virtual, first virtual introduction. That person's name is Sade Paul. She has two masters from the University of Washington, one in public health and one in public administration. Her undergraduate degree is from the University of Maryland, and she has broad backgrounds in international public health and public health research. She has, and this is something that I'm personally excited about, she served for several years as a Peace Corps volunteer in Fiji, supporting a project in Fiji that was co-sponsored by Georgetown University on palliative medicine. And she also has managed a public health research project in Kenya. She is looking forward to coming back to Maryland to focus her skills and talents on Maryland. And we want to welcome her. We also want to say we're happy to have someone with a direct link to the Chris Murray model. So, welcome, Sade.
Thank you.
Welcome.
Great. So, do we, Levon, any update on who's connected now?
I see no one connected, but there was a system message from the GoToWebinar cloud system itself that says that the entire system is experiencing random audio issues.
Yes.
So I did get that, and I think a few other people got it as well because they have sent me a chat saying as much. So I'm trying to get the general number out to everybody as fast as I can.
All right. Do the executive director, any of the center directors have additional updates?
So first, are there questions from any of the commissioners on our activities? Hearing none, I want to first off talk about our work related to COVID-19. We continue to focus on two areas, the issuance of emergency CONs and our work to expand use of telehealth in the state, and our efforts to socialize the data that's being developed by various state agencies and posted on the CRISP website. What I'm expecting to see is that we'll see some abatement in the number of hospitals, ECONs, over the next several weeks, but we do think there will be some additional expansion on skilled nursing facilities seeking to align their buildings with the directives that have come out from the governor and Secretary Neal. There also seems to be some interest on the part of hospitals in repurposing skilled nursing spaces for alternative sites. So alternative sites for hospitals in which the hospital themselves would run the space at the nursing home. Yesterday, I gave a presentation to the Joint Legislative Task Force on COVID-19. I will share that presentation with the commissioners later today. One key point that I emphasized.
Hello? Does
Hi,
anyone hear me?
Yes, I can hear you loud. Good.
Oh, thank God. Thank you.
So what I did try to characterize is our work on ECONs for hospitals, and in parallel to that, the work that the Office of Healthcare Quality has conducted to issue temporary licensure for hospitals bringing existing physical bed space back into operation. What we've seen is that hospitals have made bringing existing physical bed space back into operation. We've then seen them look at space within their own walls to repurpose administrative space, conference rooms, etc. Then they, after that, have placed a priority on using adjacent medical office buildings and other sites on the campus that could be used for temporary bed space, followed by there's about 20 hospitals that are in various stages of establishing field hospitals on their campuses, and you'll hear more about that momentarily. And then lastly, and in only a limited number of situations, we've seen hospitals repurpose closed facilities, the two examples being Laurel Regional Hospital and Adventist at Tacoma Park, which are in the process of opening. Other remote sites are also being considered, and they have they're more challenging due to the staffing and issues related to clinical management. But as the pandemic progresses, we are going to likely see more efforts to set up these alternative sites. One thing that is clearly not converging is the estimates on the models. The Washington model that has garnered the most national attention, the IHE model, seems to be quite a ways out there in terms of forecasting an early apex of the surge. In Maryland, the IHE model seems to be showing we're hitting our high point of wave one right now, and in some places, some jurisdictions, some counties, we are a day or two past what the model forecast is as the apex. The local models are forecasting an apex later in April or even early May, demonstrating that the data that is elevated in various models is very uneven, thus showing no convergence yet on model results. Clearly, they give us some indication based on what the key variables in those models are on what's happening, but I think it's safe to say that we're not out of the storm as of yet in Maryland. Continue to escalate, and which is, of course, a trailing indicator of the strength of the pandemic, but it is significantly grow. Consistent with that work, David and his team is continuing to work on elevating the use of telehealth. We'll be working with the Department of Aging tomorrow to develop strategies for potentially unveiling that technology to caregivers who may need to visit vulnerable populations via telehealth in their homes. And in terms of data, David and his team are working with the Council of Governments to make information currently compiled by various agencies in the state available to a broader network of public health and hospitals in the District of Columbia and Virginia, with comparable data sharing from those jurisdictions, which is valuable for the National Capital Region, since the health resources in the National Capital Area are distributed across 3 jurisdictions, and having a viewpoint on how that is being, how various facilities are being used is key to each of the operators in the respective jurisdictions. More on that, but we think that is very promising, and we'll hope to bring that online by next week. I think everyone is closely following what's in the press in terms of availability of beds and ICU beds and ventilators. Overall, Maryland seems to be in a pretty good space, although there are spot shortages depending on areas of the state in where there are significant outbreaks. The governor and the deputy secretary for public health have highlighted that a little more precisely than I wanted today. But if you need more information, feel free to reach out to me and I can get that in detail. I'll pause there for questions.
Questions for Ben?
And this is Casey Boyer, Commissioner Boyer. Quick question, and it's maybe it's getting us to proactively think ahead for the next General Assembly session. Do you think it's probable that the Assembly is going to ask us for a Maryland Healthcare Commission or the department, for that matter, to make any kind of recommendations as an after-action report? And if so, what steps should we be taking? Should we be putting together maybe an ad hoc committee to assist in any way?
I think the energy right now is focused on getting through wave one. I think the points that you're raising are really important, and it's not only the legislative session, it's as we contemplate reopening. And some of the IHME model in the data I shared with you from the hospital-specific website does by jurisdiction provide a forecast when we'll have 0 hospitalizations in respective jurisdictions. I would caution you as to not take that as gospel, but it is helpful. And I think our first step will be working, of course, under the direction of the governor, but also getting input from commissioners on how we reopen the organization ourselves and operate. You know, we are going to be in a completely different world, and I think the first step will be how to protect our employees as we look down, you know, perhaps as little as 3 to 4 weeks from now to perhaps 6 weeks from now to reopen. But clearly, I think the evidence by the General Assembly's interest in what the Healthcare Commission was doing in my presentation yesterday, I think that's an important point to think about going forward. As the chair has emphasized, this is the equivalent, or maybe it wasn't the chair, but you can think about this as the a century or more event. I'd liken it to the meteor hitting the Earth during the Jurassic period. Things are going to be much, much different, I think, in terms of how organizations have to operate going forward.
Is there any impacts that we should be thinking about, either the short term and the long term? I can see absolutely, you know, a reevaluation, or at least a after action, pros, cons, and, you know, what worked, what didn't work, what we need to improve for the emergency CON process, and to get that into either legislative language or regulatory language. But is there anything else, maybe requirements or thing modeling or anything else that we need to start looking at? Because as you said, that this is going to change the way we deliver healthcare and other services throughout our communities.
Can I make a brief comment just to follow up on this? This is Commissioner Thomas. I think that the other thing else being alluded to is that we as a commission pay a lot more attention to the racial and ethnic health disparities that COVID-19 has now exposed as a very vulnerable point, and how different populations are going to experience our healthcare system with their underlying conditions. That somehow we make it more explicit when we're looking at CONs and other activities to probe how the systems are addressing these populations.
Thank you. I had, Stephen, when you were off while you had been dropped from the call, I reached out and asked you to make a couple comments. It's probably a good time now to talk about the work you've been doing in conjunction with, I believe, a group from the governor's office to sort of understand the racial disparities around the current crisis. Would you be willing to make a couple comments on that for us?
I'll just, and I'll be brief. Let me just say that in watching the events unfold on the television, um, there was a national surprise. I wasn't surprised because I've been in this space for 30 plus years, but a real surprise when we saw these differential impacts on African Americans and Latinos. And I think for the first time, the American people more broadly heard the term health disparities. And we have to understand that for a lot of folk, even this public health frame that we're talking about, infectious disease, is new to them. And I can only imagine even on the governor's team, there are legislators and other leaders getting a one-on-one, public health 101 from Fran Phillips in the face of this. So we would really like to just help the state address these health disparities. And for my other commissioners, I just want you to know that in these minority communities, when we have people on the ground, there is misinformation being disseminated, conspiracy theories, materials telling African Americans and Latinos that they should not take the COVID-19 test, they should not take the vaccine. And we have no real systematic countermeasures to address this misinformation campaign. So we think that this represents a gap in our strategy that needs to be shored up. And I agree with Ben. We need to be batting down the hatches right now for the next wave. And I think racial and ethnic health disparities becomes a central issue. So we're working as best we can with Fran, the governor's office, the state's Office of Minority Health, to see how the university can bring its manpower, its technical expertise to help mitigate what will be a very devastating impact on Maryland's racial and ethnic minority communities. I'm right here in Prince George's County, the epicenter of the state of Maryland, and I think people are just totally shocked. So thank you for allowing me that bit of time, and as plans mature, we will be sure to report back to the commission. And then the after event report, I hope the commission can play a leadership role in hosting forums around the state to address this issue in particular. Thank you.
Thank you, Stephen. Appreciate that. Any of the center directors have any updates, Ben?
This is Marcia. May I ask a question?
Sure.
Hi. I don't know when the appropriate time for this would be. If later is fine, but I'd like to better understand what the Healthcare Commission could do in terms of the crisis in the nursing homes to prevent this from ever happening again.
That's a full question. I think that after this event, excuse me, after this event, we're going to want to take a look specifically at the different hot points of challenge that have popped up throughout this time, nursing homes being one of them, and understand where there's opportunity to do better. The challenges that we've seen in the nursing home industry have been present throughout the country in nursing homes, and that there, to some extent, this is a challenge with pandemics, and I think there are going to be opportunities in nursing homes to learn from this and opportunities to change the way that care is delivered to reduce that risk. Again, I think as we get into the next phase of this, which is the after action, will be the time for that. As Ben sort of pointed out, the resources of the department and to some extent the commission right now are all in on this initial response phase. But the point that you're raising is a very important one, and one we want to keep on the list of things to look at when we get to that phase of organizing ourselves around the after action response.
Thank you.
Then we get back to that last question about do the center directors have any additional updates? Ben? Are you muted?
I think there are no center directors with any updates.
Great, thank you. So, moving on then, before we consider action items today, I want to remind commissioners that if they wish to recuse themselves on any action item, they should inform the chair. Since this is a remote meeting, you can't move to the small conference room, but commissioners who are recused should remain silent and mute their phones. Again, before you recuse or say anything, please identify yourself. It's just much easier for those listening to keep track of what's going on. Moving on in the agenda, we'll move to agenda item number 3, which is an action item. Items 3 and 4 on the agenda involve emergency certificates of need issued by the executive director since our last meeting on April 3, 2020, which now require confirmation by the commission. We'll first deal with item 3, which involves a single emergency certificate of need that permits any Maryland General Hospital to establish one or more field hospital inpatient units on the hospital grounds. We'll now hear a brief review of this emergency CON by Paul Parker, Director of Healthcare Facilities Planning and Development. Paul?
And Sue Ellen is also connected and can talk. Paula, however, I don't see with the audio yet.
Paul? Are you there yet? So I have Paul up for items 3 and 4 on the agenda.
So Martha was dialing in on 410-610-2728, says she can hear, but we can't hear her, which I think we agree. Jason, who's on 301-257-0998, can hear, but he can't talk.
Lon, any thoughts?
Paul, I reset him the pen to be able to talk. The system is telling me it has not been entered yet, but I am getting a lot of messages that there are a lot of connectivity issues just trying to even get to this. I don't know if it's an internet issue or what. But I see Paul's name, but I do not see anything where he can talk yet.
Martha is on the phone at 410-610-2728.
Yeah, I don't see any telephone numbers. If someone just calls in, I don't see them on my list. So I've provided the number that they should call if they want to come in as a panelist, which means they can speak. I sent it to everyone, and I also have emailed it out.
Hi, this is Martha Reimer. Can you hear me now?
Yes.
Yes.
Martha, we can hear you.
Okay, good. Thank you.
Martha, excuse me, what did you just do to bring yourself on unmuted?
So I turned off my internet access and only went phone access only, and that's what I'm on now, my phone.
Okay, stay tuned.
The internet, unfortunately, is extremely slow. A lot of places today, there's a lot of issues going on, so we just need to be aware of that.
So do you think maybe COVID infected the internet?
No, phone is actually probably a better connection today using the satellite than the actual internet. So for those who are calling in with cell phones, that's actually probably a better connection.
And Paul has the cell phone number and he's calling in right now?
I do not know if he's calling, but I make sure that he has it.
Paul, are you online? Mr. Chairman, I'd suggest we go to Teresa Lee. That's just a presentation. Teresa, I believe, is speaking.
Agenda 6 or 7? No, agenda 8.
Same situation.
The overview of hospital rating systems.
Yes.
That's Courtney Carter.
Senior staff.
So, is Courtney available online?
Courtney has the dial-in number and should be available.
Courtney, can you speak?
Teresa, can you?
Courtney, can you hear? Can you talk?
Yeah, this is Courtney. Can you hear me?
Outstanding. Can we get Courtney's slides up?
Yep, I'm pulling it up right now.
All right. Courtney Carter, Chief of Hospital Quality Initiatives, will provide an overview of national hospital rating systems that are designed to guide and support informed decision-making among consumers of healthcare services.
Okay. Thank you for the introduction, Chairman. So back in February, I gave a brief update on Maryland hospital performance for some of the recent releases of hospital rating systems. So in response to that discussion, we've developed a more comprehensive overview of the different national rating systems that are out there. And we pay attention to these different systems because it aligns well with our public reporting efforts and it gives us a broader perspective on hospital performance. So next slide. So today I'll just give you a brief overview of what rating systems are and I'll discuss some of the more common ones. And we'll talk about some variations and I'll also talk about some of the strengths and observations or critiques. And then I'll end with some of the main takeaways. Next slide. So national hospital rating systems exist to measure various aspects of healthcare quality, and then they deliver that out to the consumer. So there's about a dozen systems that either rank or rate healthcare, particularly hospitals, in some form or fashion. So you've probably heard of many of them. We talk about CMS star ratings and leapfrog safety grades, but if you're not thinking about them regularly, some of those nuances may get, or the differences may get lost. So each system focuses on something a little different. Some systems give a summary metric for overall performance, while some may have a more focused target, like patient safety or specialty care. So also the goals tend to differ. So some systems are aiming for transparency and accountability, while others are focused on recognizing top performers. So it's also important to note there's no gold standard for rating hospitals. There's no board or organization that reviews these different rating systems, but each system does have a board of directors or a technical expert panel to develop methodologies and to decide which measures should be included. Many of the systems do use overlapping measures and data sources to arrive at their results, but if you compare their methodologies, they do end up being pretty different. So next slide, please. So this slide is not an exhaustive list, but you'll see that I've highlighted several of the most well-known systems that either get some kind of star rating or a letter grade or a ranking. So in your packets, you should have a handout called Characteristics of Rating Systems. And it's a grid with some different colored row headings. So I couldn't fit it on the slide. It was too small. You wouldn't be able to read it. So if those of you on the phone that don't have this handout, essentially it's a grid. On the left, there's a column that lists different variables, including a description of the rating system, the focus, the level, the types of measures that are included, and the data sources. And then there's a column for each of the different rating systems. So I'll quickly go over each of these systems. The CMS overall star rating is a summary metric. This is used for consumers to judge overall hospital performance. It's sort of like the Yelp review of hospitals. And it's based on 59 different measures across 7 different categories of quality. The next column is U.S. News and World Report. They rank high performers for 9 common conditions and procedures, and also 16 different specialties. The next column over is health grades, and they name the top 1, 2, and 5% of hospitals nationally, and their list is based on 32 common conditions and procedures. The next is Leapfrog Hospital Safety Grades. They assign a letter grade to hospitals based on certain patient safety measures, which is based on 15 process or structural measures and 13 outcome measures. The next column is the Commonwealth Fund. So this is an important rating system that we pay attention to because it gives a nice overview of Maryland's overall health system performance. So it's not strictly limited to hospitals. It also includes some behavioral factors and some policy issues and some additional healthcare settings. It gives an overall picture of how the state performs nationally. And then the final column is not a rating system, but I did include the Maryland Healthcare Quality Reports website. So this is MHCC's consumer-based quality site, and I just really included it for comparison purposes to give you an idea of the type of measures and the data sources we use for public reporting. The table is more or less self-explanatory, but essentially if the characteristic on that left-hand column applies to that particular rating system, I put an X in the applicable box. So what I want to say is that more X's down the column does not necessarily equal a better or more robust system. It just means that that measure or that data source applies. So if you look about halfway down, there's a row called Types of Measures that's highlighted in blue. And that first sub-bullet says structural or process measures. And if you go across the row, most of the different rating systems include some type of structure or process measure. But CMS might use 10, whereas US News might use 3. So it doesn't really indicate the weight. So I think I'm going to pause if there are any questions on this table. If not, I'll move to the next slide.
So this is Dr. Bhandari. Who rates these ones? Is it by the consumers?
I'm sorry, can you repeat the question?
Who rates these? Who provide these ratings? The consumers like patients, or there is how they rate all these things?
Right.
Send
So
these
there are
surveys
different
to the patients, or how the ratings are, how they collect
right.
this data?
So there's the organizations collect different types of data. Most of them will use some data from CMS. If you look down at the last row heading that's blue that says data sources, you can see where they get their data. So a lot of it is administrative data that they may pay for. Some of the different systems use their own proprietary survey data. Others might use data from AHA. So there's a variety of different sources.
Thank you.
Mm-hmm. Okay, so I'll move to the next slide. So as I've alluded to, there's a lot of variation in the methodology, which means there's going to be some variation in results, even though the measures and the data sources may overlap. So I pulled out 2 hospitals to give you an example of how the interpretation may get a little bit confusing. So on this, the left-hand column is just the logo for some of these different rating systems. So you probably recognize some of those. And then in the center column is St. Joseph's Medical Center, and these are real results, the most recent. So if you look down the row for St. Joe's, they do pretty well. They're pretty consistent, 5-star, A safety grade. But if we look over at the next column, which is MedStar Franklin Square, CMS tells us that they're a 2-star hospital out of 5. But then we look at patient safety, and they got a B, which isn't bad. And then US News tells us that they're actually the 10th best hospital in Maryland. And then Health Grades takes it a step farther and says that Franklin Square is actually in the top 1% of hospitals nationally. So it's a little bit hard to digest that a 2-star hospital could be among the top 1% of hospitals in the country. if you don't have the correct context around what these systems are actually looking at. So just remember, if we go back to this grid, Healthgrades only looks at common conditions, whereas CMS takes into account a lot more measures like infections or hospital-acquired conditions. So you can see how these results might confuse or mislead the average consumer who may not be aware of the difference in these rating systems. Also want to point out that these are both two extreme examples. I really pulled them just for illustrative purposes, but most hospitals do fall somewhere in the middle. So a 5-star hospital won't always be equivalent to an A safety grade, but you typically won't see a 5-star hospital with a D safety grade. Okay, next slide. So you might be wondering why rating systems that use overlapping measures and data sources can come up with such different results. So this slide is a pretty good visual of how complex the methodology can be. This depicts the CMS star rating methodology, and you can see how many steps and calculations and statistics are involved. So it's really not straightforward, and it gets pretty complicated once you start teasing it out. Next slide. So on this slide, I've just listed some of the strengths of rating systems in general and how they can benefit different types of healthcare stakeholders. So first, the ratings can really act as a baseline for performance and comparison. So in this day and age, you can pretty much find information on any type of service. You can Yelp, or you can look on Amazon reviews, or you can find reviews on social media. So if someone's anticipating a surgery or procedure, these rating systems really can help guide and supplement that research. Providers can also use these results for referrals, and hospitals can use the results to help inform performance improvement efforts. So for example, if a hospital receives a low grade on the Leapfrog score, they could pinpoint a certain area, a certain infection type maybe, where they want to target their improvement efforts. And then finally, measurement science is it's evolving. So measures are regularly changing. They're either being added or retired, or definitions are changing. So these systems do tend to take that into account, and they're able to adjust their methodologies to adapt. And currently the CMS star rating is under review. So that methodology will change next year, and it's being tweaked based on stakeholder and consumer feedback. Next slide. Okay, so there are also some observations and some critiques we've made of these rating systems. So first, the results might appear to present conflicting information, which I think I demonstrated on that slide where we compared the two facilities. It could be challenging for the everyday consumer to be able to interpret what it all means. You know, just because your hospital might only get 2 stars doesn't necessarily mean it's a bad hospital. It's also important to recognize that there are some limitations with data and sources used. Some systems rely heavily on administrative data. Some measures used aren't risk adjusted. Certain measures are used more for internal hospital surveillance purposes rather than analysis across facilities. So there are just some inherent limitations with certain data sources there. Rating systems also end up comparing non-like hospitals, which can be problematic as well. Smaller hospitals might only have enough data to meet thresholds for half of the measures required for certain rating systems, whereas larger academic hospitals are submitting all of their data and they're being compared equally. So conversely, large hospitals tend to take on more complex and higher acuity patients. And one of the criticisms of the CMS star rating is that larger academic facilities might be dinged or penalized for poor outcomes when they're being compared to these smaller hospitals that don't provide that type of service. And finally, not all of the methodologies are transparent. So I showed you that CMS framework, but clear methodologies are not really available for each system. I did some digging, and some of the websites have a general methods description, but it's not really apparent how they got to their results. And some systems do use proprietary data, so it's unable to be replicated. Next slide. So just a couple of takeaways here. I think it's really important that we use caution when we interpret these results. Just always ask yourself what the intention of the rating system is and what information does it actually deliver. The results should supplement decision making. It shouldn't be your primary driver. So these results can't and shouldn't replace a clinician's expertise or advice, but it can be used as a starting point for discussion if the patient has any concerns. It's also important that we just use due diligence when referencing or explaining these results and giving, it's important to give the proper context around each system. And lastly, I mentioned this already, but measurement science, again, is evolving. So as data and reporting mechanisms get stronger, and as measure definitions continue to develop and get a little tighter, I think these rating systems and methodologies will adapt and become more robust in the future. And that is all I have, so I'd be happy to answer questions.
Thank you very much. Are there questions for Courtney? Courtney, I have a general question you may or may not be able to answer, but you mentioned that the CMS 5-star rating system is going to, is evolving right now, and that a new iteration is expected out shortly. Do you have any insight as to what aspects of that are going to change?
I'm not sure. Just they may consider stratifying hospital size to be able to compare like hospitals. But other than that, I'm really not sure.
Got it.
This is Dr. Bhandari. I can chime in. I think it can be very confusing for the consumers. I can tell you from a physician point of view, it can be very, very difficult and biased for the consumers. I, in fact, contacted HealthGuard myself, and now all the physicians and practices and the hospitals are trying into this rat race. They are a system where they want to upgrade their grades. So when I asked HealthGuard, they say, well, you should ask more patients to grade you. You know, the question happens is patients, those who are happy, sometimes they don't grade because they are happy. The patient, those who are not happy, they will grade you and they give bad grades. So it has to be taken with a grain of salt, especially for the physicians' practices. Hospitals has its own limitations.
Thank you, Commissioner. Paul, are you back on the line yet?
This is Paul Parker. Can you hear me?
We can hear you, Paul, loud and clear. Welcome. All right. I'm going to move back to agenda item number 3 at this point. So this, as I introduced previously, involves a single emergency CON that will permit any Maryland General Hospital to establish one or more field hospital inpatient units on the hospital grounds. Paul, the floor is yours.
Yes, thank you. Yes, as described, this is, I would say, kind of a blank check emergency CON for the Maryland Emergency Management Agency to stand up these field hospitals. So these are tents that will be equipped with beds. And between April 5th and April 8th, we did issue 6 emergency CONs for the first field hospital deployments. But given that this was a fairly fluid situation, and MEMA is really in charge of deploying these, we decided it would make more sense to issue this general emergency CON on April 10th that would basically allow MEMA to make the decisions to stand up these field hospitals when and where as needed. The first 6, just very quickly, Frederick Memorial Hospital in Frederick, 20 field hospital beds. Adventist Fort Washington Medical Center in Prince George's County in Fort Washington, 20 field hospital beds. Northwest Hospital Center in Randallstown, Baltimore County, 20 additional beds. Anne Arundel Medical Center in Annapolis, Anne Arundel County, 60 field hospital beds. Holy Cross Germantown Hospital in Germantown, Montgomery County, 20 field hospital beds. And Mercy Medical Center in Baltimore City, 10 field hospital beds. So those were the specific emergency CONs that we issued through April 8th, and now under the April 10th general emergency CON, we will have additional hospitals that will have that resource. So unless there are any questions, we would ask the commission to confirm that April 10th general CON, which would of course also include these earlier field hospital CONs that we issued.
So before we take questions, do I have a motion to confirm the approved CON issued to Maryland General Hospitals regarding establishment of one or more temporary field hospital inpatient units on a site of a Maryland General Hospital?
So moved. This is
So
Commissioner
moved.
Thomas.
Who was that?
I'll
Who else
second
was?
Boyle.
Commissioner
Boyle.
Thomas.
Thomas made the motion, Boyle seconded. Okay, very good. Discussion.
So
I have a question.
this is Dr. Bhandari. So where they are making these temporary inpatient units, wherever space is empty, suitable for the patient care?
Not sure I understood the question.
I'm sorry, yeah. Could you repeat the question?
Where are they making these temporary field hospital beds? So space, whichever is available in the hospital, does it need to meet certain requirements, or they can find any place and they can convert into patient rooms or beds?
Hospitals are not, the hospitals where these field hospital units are being deployed are not just using these field hospitals for expansion. They're typically also looking at putting beds temporarily into operation within the hospital building proper, or actually looking at other types of spaces where they can temporarily expand beds. I'm not sure if that's answering your question.
No, that's
But
fair
these
enough.
aren't beds that go inside the hospital, right, Paul? These are beds that go outside the hospital on the ground.
Yeah, these will be built outside, adjacent to the hospital.
Right.
That's my question was. Okay, thank you.
Okay. So I have a question. Of the field hospital beds that have been built thus far, first of all, first question is, how many field hospital beds do we have that are open right now? And how many do we have that have patients?
Well, based on the information on how quickly these can be set up, it looks like the initial batch of emergency CONs that we issued, that was about 150 beds. I'm not sure how many, or if we know exactly how many MEMA has access to ultimately set up. Maybe Ben might know what that answer is. I do not.
So can I speak? I'm not sure.
Yep.
So
Go ahead,
the
Ben.
plan, the 50 field hospitals, field tents have been, I believe, ordered, and tentative locations have been identified for the first 50. It's at approximately 35 locations. That does include some prison locations. Jessup, for example, is taking 5 tents. To Dr. Pollack's questions, I believe that the Adventist Hospital at Fort Washington has 3 tents. I believe that one of those tents is actually taking patients. Frederick, I think, is either completed or nearly completed, and they only have 1 tent currently set up. They perhaps are looking for more. Anne Arundel had requested 4 tents. I'm not sure what the status is of that, but to be on tents, I think that's what Paul pointed out, is that the situation is kind of fluid because the penetration of the virus is different than might have been anticipated 2 or 3 weeks ago. So some who say we needed 4 tents now say they need 1 tent or 2 tents, and those that have said we don't need any tents are now suggesting they might need one, and vice versa. So thus the need for a general approval, we think, which will allow MEMA to move ahead quickly with hospitals without the hospitals coming back to us and saying we can't bring this into operation because we haven't had an approval from the Healthcare Commission to open up these temporary beds. The biggest focus on the field hospitals, however, is not on the hospitals themselves. It's in the correctional facilities where, as Commissioner Boyle observed, institutional sites are hotbeds for virus spread.
Thank you, Ben. Any further discussion? I have a motion and a second on the floor. All in favor?
Aye. Aye.
Aye.
Aye.
Aye.
Okay. Any opposed? Very good. On to agenda item number 4, other emergency certificates in need. Item 4 involves a number of emergency CONs. Thank you. As at our April 3rd meeting, we'll deal with these as a group with a single vote for confirmation after a brief review of the projects by staff and an opportunity for questions by the commissioners. The commissioner wishes for the commission to vote separately on a specific emergency CON. That commissioner may make a motion. If seconded and adopted by the commission, the particular emergency CON will be considered separate. We'll review each emergency CON and pause for questions before moving to the next. Paul, please proceed.
Yeah, this is Paul Parker. Hopefully you can still hear me. We have 8 emergency CONs here that expand hospital bed capacity and 1 emergency certificate of need for a nursing home project. The first 2, 4A and B, I will talk about together because they're basically related. White Oak Medical Center, Adventist White Oak Medical Center, opened in 2019. The hospital that it replaced is still intact and was being used in certain ways, has been used as a special rehab hospital, and the emergency room was also being used as an urgent care center. So the first project involves going back into the former Washington Adventist Hospital in Tacoma Park and setting up 63 beds for operation in that facility. That should be online already based on the information we had on that project, and the estimated cost is about $500,000. I'll pause for any questions on that one. And hearing none, we'll go to 4B. This again is Adventist Healthcare, and at the White Oak Medical Center itself, the relatively new hospital that replaced Washington Adventist, they are proposing to go into individual nursing units and add beds in space that was available in those units that they could reconfigure. So they're getting small numbers of beds on a number of individual nursing units, a total of 23 additional beds in White Oak Medical Center. They anticipate that about half of these will be ready to put into operation by the end of May, and that the rest will be available by the end of June. And they are estimating the cost of reconfiguring these existing nursing units at $5 million. Any questions on that one? Hearing none, I will move on to the next emergency CONs. So 4C, D, E, and F are all projects by Kaiser Permanente. They have a number of fairly large outpatient service centers located throughout the state. And these 4 emergency CONs involve putting beds in place at those facilities as temporary hospitals. In the Largo facility, which is 4C, that will be 68 beds at an estimated cost of $600,000. And all 4 of these projects, they anticipate having the ability to put them in place by April 27th. If there are any questions on 4C, I'll pause for a moment. 4D is the same type of project. This is at the Kaiser Permanente facility in Gaithersburg in Montgomery County. 49 temporary hospital beds. I'll note that all of these are for lower intensity patients, so they don't intend to have anything like an intensive care unit or a ventilator unit type of facility. These would be intended for use by patients who are not COVID-19 patients or who have recovered and are now able to spend maybe the last period of convalescence at one of these facilities. So this facility is about $400,000 for 49 beds in Gaithersburg. Any questions on that one? Moving on, the next one is a similar project. This one would be at Kaiser Permanente's Baltimore County Center, which I believe is in Hale Thorpe, and that's 45 inpatient beds, and the estimated cost is $400,000. And if there are no questions, the last Kaiser Permanente project is at their oldest outpatient center, I believe, in Kensington, which is a bit smaller. They are proposing to open 10 beds as temporary hospital beds at that facility, and they estimate the cost to be about $100,000. So if there are no questions on those, I'll move on to 4G. This is Holy Cross Hospital of Silver Spring, and they want to establish 84 additional inpatient beds. These are space that was basically older nursing units that were retired from service a few years ago when that hospital did a major expansion and renovation. And so the wings are still there, the units are still there. They haven't knocked them down yet or reconfigured them in any drastic way. So they're going to bring those back online. The estimated cost is $11 million, and they anticipate that they could have those beds up and running by May 15th. Any questions on the Holy Cross Hospital project? Okay, 4H is in Harford County, and this is establishment of a 13-bed behavioral health unit in a remote location. So the psychiatric beds in Harford County are currently operated in Havre de Grace at Harford Memorial Hospital. This would provide more space, I think, at that facility by temporarily relocating, some portion of that service to a crisis center in Bel Air. Estimated cost is $155,000, and they estimate they can bring that online by April 27th. Any questions on that project? And then the last one, 4I, this is a nursing home project, Stella Maris, which is a large nursing home located in Baltimore County. Wants to establish up to 39 additional beds in 2 COVID-19 units. The first would be 18 beds, and that would be their primary move here. And then the second one, if needed, would be an additional catch of beds that they would actually set up in an adult daycare space. Both of these projects would take about 7 days to put in place. So, if there are any
This is
questions on
Marcia.
Belamiris?
Yeah, this is Marcia. What would they be doing in terms of safety that may be over and above what they might have done before this pandemic?
Well, these are both areas. The two areas that they're talking about setting up beds are isolated from the rest of the facility. So they believe that they can operate these, from a proximity standpoint in a way that really keeps any patients in these, keeps any contact with any other patients. Basically, there wouldn't be any.
Yeah, I think what they're proposing there is absolutely fantastic because it'll create nursing home capacity for COVID positive patients, which is something that we just don't have in the rest of the state right now, in inadequate numbers at least. And it does it in a way that completely separates them from the rest of the population in a separate building. So this is sort of the model of how to do it. All right.
So funding for these projects will come from which sources?
Well,
many of these projects, certainly most of them, I think the cost of doing these projects is modest enough that there isn't any sort of debt financing plan. They're being funded from cash on hand or philanthropic donations. But these are projects that are being paid for by the individual facilities.
But the funding source is identified in each one of these packets, right?
I'm sorry, could you repeat?
I said the funding source has been identified in each one of these packets.
Yes.
Yeah.
Question,
And if they have to
Commissioner
reapply
O'Connor?
for the current, it's only for temporary certification of need, right?
Yes.
Commissioner O'Connor, I have a question. Can you hear me?
Yes, go ahead. Yes, I can hear you.
In regard to item G, I think Paul mentioned $11 million to just renovate 84 beds that already exist. I just thought that was a lot of money to rejuvenate 84 beds that already exist. Is there something I'm missing there?
I don't think so. I mean, you have, I'm not exactly sure what shape these units are in. I think they have been closed for around 10 years now. And there may have been some temporary, they may have been repurposed for other uses. So they will, I'm sure, not only have to do some actual physical renovation of the space, but then they'd have to buy equipment. And I would expect that a lot of that expenditure is actually going out and getting, the types of equipment and furnishings that they need for these rooms, because I don't think they've had them sitting around with that in place.
Excuse me, Paul, if I can interrupt. So one of the reasons that these are more money is the head walls were taken out when the rooms were deactivated. I had a brief conversation with Holy Cross about that, and consequently, that was what the explanation they gave me. Not sure it's completely explains it, but I think putting head walls back in could represent a sizable cost.
That's pretty quick, though.
The same in the RT number 2, I think that was 23 bed, about $6 million, right?
Sorry, could you repeat that?
Item number 2 was also $6 million, which this is a new hospital, right? Item number B as in boy, 23 inpatient bed, that cost about $6 million. I think that's what all you mentioned.
$5 million was the estimate.
Yeah,
But it's a
that's lesser
similar.
than what comes across 84 beds.
Yeah. There's variability that we've seen in all of these emergency CONs in terms of cost per bed. And I think that's we talked about last time. It's something we sort of have to be able to swallow in this process. I think the highest cost per bed we saw thus far still is the Mercy project that was essentially the first one to come through, which was complete build out of a shell space on the 11th floor or something of their new tower. A project that clearly is highly unlikely to be completed during this crisis. Nonetheless, we approved it because we felt that there was really no way to understand what the back end of the crisis was, and then the bed need situation was very, very real. The issue that these institutions all have in investing big dollars like this is that they may or may not be able to garner additional support for funding after the fact. But in order to keep those beds online, they'll obviously have to submit a new CON that justifies the bed capacity afterwards. And then in order to keep them running, they're going to have to be able to convince potentially the HSCRC to include additional dollars in their GBR. So the individual hospitals are really on the line for the financial risk in doing this in a lot of ways. And we have to, in the context of the partnership that's necessary in order to grow the bed capacity that we need, we have to sort of take a pass on asking too deeply about the cost per bed in this. Understand that they have the risk for that. Hope that they act judiciously in moving forward.
So, Mr. Chairman, Commissioner O'Grady has a question. I'm not sure if you can hear him, but let's do a sound test for him.
Commissioner O'Grady?
Hi, can you hear me now? Can you hear me?
Yes. Yes.
Okay, good. I didn't have a question. I just want to let you know that I finally got through.
Congratulations, sir. Welcome
Thank
aboard.
you. I'll go back to mute now.
All right. Do I have a motion to confirm the approved
Mr.
emergency
Chairman,
certificate?
Dr.
Yes.
I just got a message from Commissioner McCarthy that he is recusing himself on this item.
And I appreciate that based on his recent, yes. Okay. So Commissioner McCarthy is recused and has been on mute the entire time. So noted for the record. Do I have a motion to confirm the approved emergency CONs for agenda items A through I, 9 separate items?
So moved, O'Connor.
Motion from Commissioner O'Connor, and do I have a second?
Second,
O'Grady.
Commissioner Boyle.
And a second from Commissioner Boyle. So I have a motion and a second. Do I have any additional discussion? Hearing none. All in favor?
Aye.
Aye. Aye.
Aye.
Aye.
All right. Any opposed? Hearing none. The ayes have it. All righty. On to agenda item number 5. Agenda item number 5 is a consideration of 3 related projects of Upper Chesapeake Health System. Upper Chesapeake Health System is a part of the University of Maryland Medical System, with which I am affiliated. So I'm recusing myself from participation in this part of the meeting and muting myself. I'm now turning over the chair of the meeting to Vice Chair Sargent. Vice Chair Sargent?
Thank you.
Vice Chair Sargent? Yes,
Yep.
Vice Chair Sargent. This is Casey Boyer. As an elected official from the city of Havre de Grace, I need to recuse myself from this matter. I'm going on mute now. Did you hear me okay?
Yep, we can hear you fine. Thank you. So we have 2 commissioners recused. Does that anyone else need to recuse, or are we good? Okay. So Upper Chesapeake Health System has proposed 3 projects that will reshape hospital facilities and services in Harford County. It proposes to convert one of its 2 Harford County hospitals, Harford Memorial Hospital in Havre de Grace, to a freestanding medical facility to be developed in Aberdeen. This first of the 3 projects requires approval of a request for an exemption from Certificate of Need review. In conjunction with the first project, Upper Chesapeake Health has proposed to expand and add bed capacity at Upper Chesapeake Medical Center in Bel Air. This second project is also being considered as a request for exemption from CON review because it is a project involving the consolidation of the facilities and services of 2 hospitals. Third and finally, Harford Memorial Hospital has operated the only psychiatric hospital service in Harford County. In order to preserve the availability of this inpatient service in Harford County following the conversion of Harford Memorial to a freestanding medical facility, Upper Chesapeake Health System is proposing to establish a special psychiatric hospital on the new medical facility campus in Aberdeen. Establishing this new hospital requires a Certificate of Need. So although these projects represent a package of related projects, they are individual matters. So Kevin McDonald, the Chief of CON, will briefly review these projects separately.
Thank you, Commissioner Sargent, and good afternoon, Commissioners. As Commissioner Sargent summarized in this agenda item, it includes 3 interrelated projects from the University of Maryland Upper Chesapeake Health System in Harford County. I'll give some background and context for the total package and then address each one separately. Upper Chesapeake Health System operates the only 2 hospitals in the county. Upper Chesapeake Medical Center opened in Bel Air in 2000. It has a physical capacity of 202 acute care beds and is licensed for 161. Harford Memorial Hospital was constructed in Havre de Grace in phases between 1943 and 1972. It has a physical capacity of 174 acute care beds and is licensed for 82. The applicants maintain that this set of projects would reconfigure and modernize Upper Chesapeake's delivery system in a way that will realize efficiencies and cost savings by closing Harford Memorial and replacing it with 3 projects: a freestanding medical facility to be built in Aberdeen, a consolidation of MSGA beds from Harford Memorial to Upper Chesapeake Medical Center as part of a 3-part addition, and a special psychiatric hospital to be co-located with the FMF in Aberdeen. The set of projects before you today is the 3rd iteration of these projects in the review process. Initially, Upper Chesapeake proposed to build the FMF and special psychiatric hospital on a plot of land in the Bully Rock section of Havre de Grace, very close to I-95. However, Upper Chesapeake withdrew these proposals when the local planning and permitting process resulted in requirements for infrastructure investments that Upper Chesapeake deemed to be too costly, and thus they set about seeking a different location. The second set of proposals was similar in scope, but would place the FMF and behavioral health facility in Aberdeen. It proposed a similar number of beds to be added to Upper Chesapeake Medical Center, but all of those beds were to be observation beds. MHCC staff had several concerns regarding the size of the proposed projects, which it shared with Upper Chesapeake, and Upper Chesapeake responded with modifications to each project, at least partially addressing each of the concerns. And that modification resulted in the projects that we'll be reviewing today. The total estimated cost for the 3 projects is just over $204 million. The applicants estimated that to totally renovate the existing Harford Memorial would have been closer to $240 million, and that alternative would not increase efficiency for the system and would perpetuate existing redundancies. These projects will be paid for by bonds, arbitrage from the bonds will be issued by the University of Maryland Medical System. Before getting to each project, I'll make one more comment that applies to the entire package. Staff believes that each of these facilities may be somewhat larger than our analysis would suggest is necessary, but we also realize that the one-time capital expense of some extra space is much less consequential than excess operating expense that recurs repeatedly. We don't see any risk of that occurring due to the possibility of some extra space. In addition, such concerns are mitigated by the fact that Upper Chesapeake's budget negotiations with HSCRC resulted in an agreement that is expected to save ratepayers approximately $10 million in the first year of operation and about $15 million annually in subsequent years. With that background, I'll move to the specifics of each project. The first project for consideration is a request for exemption from Certificate of Need Review for the conversion of Harford Memorial to an FMF. The FMF would be constructed in Aberdeen, less than 5 miles from the existing hospital. It would have 25 emergency room treatment spaces, of which 5 would be dedicated to behavioral health patients and 17 observation spaces. It will include a diagnostic imaging suite, a laboratory and pharmacy, and related support space. The array of services and its 69,000 square feet will make it the largest FMF constructed in Maryland. Its estimated total cost is about $56.7 million. During the review, staff's primary concern with the proposal was the number of observation spaces. With a projected average daily census of 12, the initially proposed 24 rooms was well above the number that would be required at a target occupancy of just 70%. Responding to that, the applicant reduced the number of spaces to 17. We also had some initial concern with the number of ED treatment spaces, but given the applicant's higher than average percentage of behavioral health patients, staff believes that the 25 spaces is justified. In summary, staff concludes that the exemption request filed jointly by Hartford Memorial and Upper Chesapeake Medical Center is in the public interest, not inconsistent with the state health plan, and will result in the delivery of more efficient and effective health care services, and thus recommends that the Commission grant the applicant's request for exemption from Certificate of Need Review with 2 conditions. The first condition being that any future change to the financing of this project involving adjustments in rates set by the Health Services Cost Review Commission must exclude $865,036. This figure represents the estimated new construction costs that exceed the Marshall Valuation Service benchmark cost and the portions of the contingency and inflation allowances that are based on the excess construction cost. The second condition is that the University of Maryland Harford Memorial Hospital shall not close until both the freestanding medical facility and the special psychiatric hospital to be located at 635 McHenry Road, Aberdeen, Maryland, are completed, and each has been issued a license or a provisional license by the Office of Healthcare Quality. And with that, I'll entertain any questions.
Are there any questions? I have one, Kevin. We've gotten a fair number of comments of folks, talking about whether this is something that should be on the agenda now. And I do think we partially addressed that by saying that the hospital certainly won't be closing during the COVID pandemic. It's like 2 years off. But I think there was also embedded in those comments a question of whether we think that the pandemic is going to change the analysis in some way or fundamentally change how we address healthcare. And I'm struggling with how that would be factored into our analysis on this particular decision, because we are a commission that has to decide the things that come before us based on the rules that we have to apply to them. And I was wondering if you had any thoughts on that second piece.
I take it that the question is along the lines of whether the existing pandemic will, in the long run, create more demand for capacity?
Or, how should I evaluate that issue in light? Yes, or can we answer that question? Do we not answer that question? Do we think that it's not an issue? I'm struggling with how that fits into the otherwise very structured analysis that we're legally obligated to apply.
Good question.
Commissioner Sargent, this is James Buck, counsel to Upper Chesapeake. Can you hear me?
Yes, sir.
So I would like to address that. I will say that we think some of the commentary was a little bit opportunistic and was seeking to derail the projects that have been on the commission's docket for a number of years now in light of the pandemic. But to specifically answer your question about what impact future healthcare planning would have with respect to these three projects, the short answer is it shouldn't have any impact because these applications have been pending and Upper Chesapeake is entitled to its due process rights, and the commission would apply the same healthcare chapter standards that are in effect and laws that are in effect at the time these applications were docketed and before the commission, rather than some future change or potential change in any state health plan chapter.
Mr. Chairman, this is Ben Steffen. Could I also comment briefly?
Yes, go ahead, Ben.
So I've been looking pretty carefully at the state, across the state, in terms of where COVID-19 patients are being admitted. And for the most part, these patients are either very sick or it's thought that they could become very sick. For the most part, these patients are being taken to the system hospital that has the greatest capabilities, be that Hopkins main campus, be that University of Maryland Academic Center, be that LifeBridge Sinai. And what I think we're learning is that we need to be sure that the tertiary care hospitals in particular have the resources needed to respond to very sick COVID-19 patients. But it's unlikely that smaller community hospitals will be able to effectively treat COVID-19 patients given current clinical protocols that are available, which is largely some experimental drugs and supportive care. So I think as we move through this, I think one thing we can say is strengthening the strongest community hospital in the Harford County area does mean that that community hospital will have greater capability to care for very sick patients, taking off some of the load of hospitals in downtown Baltimore, where we want to send those that are most seriously ill and in need of the most advanced care. But it is unlikely that, at least in the short term, that very small community hospitals are going to be able to care for even moderately sick COVID-19 patients. Their key role will be to pass those patients through their EDs, perhaps make initial evaluations, observe a patient, but more likely those patients, if they become even moderately ill, are going to have to be taken to hospitals with significantly more vent capability, significantly more intensive care beds, which currently are concentrated in about a dozen hospitals in the state. And we clearly need to have more of those. These are the hospitals that have 200 to 300 beds, and the strength of those, I think, will tell the tale on whether we're going to be able to respond effectively to this pandemic as we move from wave 1 to wave 2, which, if it begins in the fall, there will be not 3 months of disease spread, but 6 months of disease spread and potentially a more significant rebound than we're seeing today.
Thank you. And any other commissioners, anybody else have a question or a comment? Almost thought it sounded like somebody was going to say something. I'm not sure, maybe it's background noise.
This is Commissioner O'Connor. Can you hear me?
Yes, sir.
I'd just like to make a comment. Can you hear me?
Yes, sir. We can hear you. Go right ahead.
Okay. Along the lines of what you said, Commissioner Sargent, is, and along the lines of what that representative from Upper Chesapeake said, I don't know how he can predict how healthcare will be in a couple of years when this project will be initiated. I don't think anybody knows. And he says, well, we have standards to maintain. Well, as everybody knows, we're in a state, national, and world emergency right now. And I don't think there's any standards for that. So I don't know how he holds us to those standards. I think there's going to be probably a major paradigm shift in healthcare. Telehealth will take a big hold on what's going on. And I think it's prudent to wait and see how everything falls out before we do make a decision about any permanent change, because in 2 years from now, I can't predict how healthcare is going to look. I don't think anyone else can. I think it's going to be different. Telehealth will have a big imprint. So I just want to throw that out there for everybody to think about. Thank you.
Thank you, Mr. Commissioner O'Connor. Are there any other commissioners that have comments? I will say one. I see the issue, but would be concerned with our commission not doing its business for 2 years. We have standards, and we are supposed to turn these around. And this CON has been here a long time. I don't think it's either fair to the applicants or to actually anyone involved in the process when we delay things. And I, for one, would like to see the process of getting CONs to the commission, even if they need to have issues that need to be resolved in front of the commission, go faster. So I would be disturbed to see us table something that otherwise meets the facts because we think might change. I kind of feel like I have an obligation to take my best vote today on an issue if it's right, but I don't know if other commissioners feel differently.
This is Commissioner Boyle. I agree with you completely. And Ben's description of having a strengthened hospital in Harford County resonated. So I think we go ahead.
Commissioner, with that, any additional comments, of course, are welcome, or a motion?
This is Commissioner Reimer.
Yes, Commissioner Reimer.
Yes, I make the motion to approve.
Okay, great. Thank you. Do I have a second?
Second.
So to be clear, this is the motion to approve the exemption from certificate of need review for conversion of University of Maryland Harford Memorial Hospital to a freestanding medical facility in Aberdeen. All in favor?
Aye.
Aye. Aye.
Aye.
Are there any opposed?
Opposed. O'Connor.
Commissioner O'Connor's opposed. It sounds to me like the ayes have it. With that one, I'm sorry, I'm moving my mouse to get to the next one. The next item, item 5B on the agenda, is the request for exemption from certificate of need review for the change in bed capacity of the Upper Chesapeake Medical Center. And Kevin, please tell us about this item.
All right. The second project for consideration is a request for exemption from certificate of need review for a change in bed capacity pursuant to a consolidation of Upper Chesapeake Medical Center and Hartford Memorial Hospital. The proposal would expand the capacity at UCMC to absorb beds from Hartford Memorial. It would add 3 floors totaling approximately 98,000 square feet to the Kaufman Cancer Center. The estimated budget for this project would be $84.4 million. The first floor would be shell space earmarked to accommodate cancer center growth. The other 2 floors would hold 42 observation beds and 30 medical surgical beds. It would establish a dedicated observation space for the first time in either that hospital or Hartford Memorial. Prior to this modified proposal, Upper Chesapeake had proposed that all of the additional beds be observation beds, a total of 77, rather than a total of 72 beds we see here. MHC staff pointed out that the Upper Chesapeake Health System hospitals had been using observation status at a considerably higher level than virtually every hospital in the state, and questioned the number of observation beds being proposed. The applicants responded with an internal review that has resulted in a change of protocols that they believe will result in quicker clinical decision-making and result in more ED patients being diagnosed and sent home, or the decision being made to admit them, and fewer being put into observation status. And for those in observation status, a dedicated observation unit is expected to result in a quicker diagnostic decision because of the protocols and mindset established in a dedicated observation unit that is rapid testing and getting the data to the clinicians who would make that decision. In summary, staff concludes that the exemption request filed jointly by Hartford Memorial and Upper Chesapeake Medical Center to relocate MSGA beds from Hartford Memorial to Upper Chesapeake Medical Center is in the public interest, is not inconsistent with the state health plan, and will result in the delivery of more efficient and effective healthcare services, and thus recommends that the Commission grant the applicant's request for exemption from certificate of need review of excess space for inpatient nursing units and portions of the contingency allowance, escalation, capital construction interest, and inflation allowance related to the excess construction cost. And must exclude $16,359,163, which represents the estimated cost of the shell space and the portions of the contingency allowance, escalation, and capital construction interest that are based on the excess construction cost. So
Commissioners, do you have any questions? I have one. If you could talk a little bit about, you excluded the construction costs. That is costs for the construction above the financial model that we're using, or cost of the construction for parts of the facility that would not be used for the regulated space?
There's actually two conditions, one related to excess space for inpatient nursing units, that this proposal exceeds what the standard calls for, and the standard requires that any allowance paid for by HSCRC would exclude the related costs for that. And the second condition, the 16 million condition, is the cost of the shell space and any related contingency or capital interest inflation allowance that are associated with that. So these are the conditions that are in our state health plan when there are costs that are above the specified level, the specified benchmark levels.
Okay.
Given the payment model that the HSCRC is evolving to, it's not clear that these are going to have an impact, but they are conditions that we do need to put in here in the event that they might have an impact, and because that's the way the state health plan is currently written.
Got it. Thank you. Commissioners, are there any other questions? If not, do I have a motion to approve the exemption from certificate of need review for change in the bed capacity of the University of Maryland Upper Chesapeake Medical Center in Bel Air?
So moved.
So moved.
Commissioner Jordan.
Commissioner Jordan moved. Did I hear a second? Who was that?
Second, Commissioner Boyle.
Mr. Boyle, second. Okay. Any additional discussion any commissioners have? In that case, all in favor?
Aye.
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 Any opposed? Okay. With that, I think that motion passes, and we're on to the item 5C, the certificate of need establishment of a special psychiatric hospital. Kevin, can you tell us about agenda item 5C?
Certainly. The special hospital would be built above the FMF. It would have 33 beds and shell space for 7 more, as well as a partial hospitalization program and other outpatient space. It would essentially be replacing the inpatient unit at Hartford Memorial that is currently licensed for 31 beds. I believe they are staffing 27 of those beds now. And it has been running at an average daily census of about 20 over the 3 recent years, with a average length of stay of a little over 6.5 days. The facility would be about 75,000 square feet, and the estimated project budget just under $63 million. Again, during the review process, staff had expressed concern about the need for 40 beds, which was what was in the initial proposal. The applicant's response was to downsize it to 33, but to retain shell space for an additional 7. Staff had also questioned the decision not to house a behavioral health unit at the general hospital, as is done in most jurisdictions. The applicant responded with an analysis showing that due to a very tightly packed campus, where they would have to build would result in greater costs, and that adding scale to the Aberdeen project increased its feasibility. So not only would it have been more costly to do it on the campus, but combining it with the FMF, they were getting some economies of scale. With this project, staff summary would be that we conclude that the proposal filed by the University of Maryland Upper Chesapeake Health System to establish a special psychiatric hospital meets all relevant standards in the state health. It's needed, likely to be financially feasible and viable, has strong support, is likely to have a positive impact on the health system, and thus recommends approval of the with the following condition.
Hey, Kevin, there are some very interesting noises going along. Maybe wait a second, see if whatever that was is going to. Okay. All right. Go ahead, sir. Sorry.
I'll start the summary over again. Staff concludes that the proposal filed by the University of Maryland Upper Chesapeake Health System to establish a special psychiatric hospital meets all relevant standards in the state health plan, is needed, likely to be financially feasible and viable, has strong public support, and is likely to have a positive impact on the health system, and thus recommends approval of the certificate of need application with the following condition, which is, prior to requesting first use approval, Upper Chesapeake shall submit written quality assurance programs, program evaluations, and treatment protocols for 2 special populations of patients to be treated at Upper Chesapeake Behavioral Health: geriatric patients and those with a secondary diagnosis of substance abuse. And with that, I'll entertain questions.
Commissioner O'Connor, question. Can you hear me?
Yes.
Okay. Along the lines of the big picture again, it might be a little short-sighted to not anticipate a wave of increased need for behavioral health and substance abuse beds, given the crisis we're in now. I don't think we've seen the impact of the mental health consequences of this pandemic, and perhaps, again, it might be premature to approve all these moves now instead of waiting. Thank you.
I would respond to that by saying, the applicant has reserved space for about 20% more beds than is currently being built. So, that would reinforce their decision to stay with that amount of space.
Any other commissioners or any discussion or questions for Kevin? Okay, with that, do I have a motion to approve the certificate of need for establishment of a special psychiatric hospital in Aberdeen?
So moved.
Which commissioner was that?
O'Grady.
Thank you, Commissioner O'Grady. Do I have a second?
Second, this is Commissioner Reimer.
Thank you, Commissioner Reimer. Is there any additional discussion before I call the question? All in favor? Aye.
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 Are there any opposed? Oh, thank you. Are there any opposed?
Opposed, O'Connor.
Commissioner O'Connor, thank you. Okay, the motion passes. And with that, I think I can turn the controls back over to the chair.
Commissioner Sargent, this is Commissioner Sargent. This is James Buck again from Gallagher, Avilius and Jones. I was wondering, before we went to action item 6, if Lyle Sheldon from Upper Chesapeake Health System, the CEO and chairman, has a few thoughts that he wanted to thank the commission. Lyle, are you able to speak right now?
Yes, good afternoon, ladies and gentlemen, and on behalf of the citizens of Harford and Western Cecil counties and the Board of Directors of University of Maryland Upper Chesapeake Health and our medical staff and our team members, we thank you very much. As Mr. Steffen and the staff knows, we originally met with Mr. Steffen in October of 2014, so this has been a very long journey for us. And thank you for approving these so we can continue to serve this population and transform healthcare in an effective, efficient way in Harford County. So thank you very much, and thank you for serving.
Thank you, sir. And with that, we will go to the next agenda item, and Chair Pollack will rejoin us.
Thank you, Commissioner Sargent, and thank you to Ben and Kevin. Agenda item number 6, Howard County General Hospital. Is also Commissioner Boyer back?
Yes, Commissioner
Hello?
Boyer is back. Thank you very much.
Welcome back. All right. Howard County General Hospital has operated a PCI program for emergency services, also known as primary PCI services, for over 10 years.
Excuse me? Excuse me, I
Yes.
apologize. This is Commissioner Boyle. I need to recuse myself from this one.
Thank you. Thank you for stopping me. Howard County's applied for a certificate of conformance to add elective PCI services. It is one of only 3 programs in Maryland that currently has only emergency PCI services, and this will be the 3rd time that the Commission has considered approving the addition of elective PCI services to an existing primary PCI service program. Paul Parker, Director of Healthcare Facilities Planning and Development, will provide an update on this matter. Paul?
Yes, this is Paul Parker. Can you hear me?
We can hear you.
Good, great. Chairman Pollack, members of the Commission, this is a request for a certificate of conformance. A certificate of conformance is a special type of review process created in statute just for consideration of percutaneous coronary intervention services. And as the chairman noted, Howard County General Hospital is one of a small number of general hospitals in the state that has only been authorized to provide primary PCI services. These are for patients who are experiencing a heart attack. And so this is an emergency procedure. And they now want to, in addition to providing primary PCI, provide elective PCI. And so our review of this first looked at their track record in providing primary PCI, which is extensive. They've been providing primary PCI services since the last decade, and that track record is a good one. They have met our requirements for program case volume, for interventionalist case volume. They've had an acceptable door-to-balloon times. So they've been doing a good job with primary PCI. And then turning to the standards specifically for elective PCI, there's 5 major areas here. They satisfied to the staff's view the need for elective PCI being added to this hospital's program of services in order to preserve timely access to primary PCI. As we have more and more elective PCI programs, primary and elective PCI programs throughout the state, we are closing the geographic gaps that exist, and of course that geographic distribution is very important in terms of primary PCI, because we want to get patients experiencing a heart attack to a primary PCI program quickly in order to get the benefit of that treatment option. And in this case, when you look at Howard County, there's certainly, we can reach alternative sites for primary PCI within the 30-minute travel time that we use as a benchmark here. But in the analysis of this issue that was done here, you will see that we came to the conclusion that there were many areas of Howard County, the Howard County General Service Area, where we would see a significant increase in travel time if we did not have the primary PCI program there in Howard County. And having elective PCI certainly makes this program a more stable program going forward with a larger base of operation, and probably helps with maintaining a stable staff of interventionalists and the other PCI staff as well, and assuring that it's going to be a viable service to provide going long term. The second thing we looked at is the case volumes, and we think that there's a very good likelihood that this program will reach 200 cases, 200 total PCI cases per year, which is our standard. They're doing about 100 primary PCIs in recent years. It looks like the big shift that we would see by moving to elective PCI at this location would be from the Hopkins facilities in Baltimore City. Howard County General Hospital is part of the Hopkins Health System, and so we think that's where most of the elective PCIs that will be picked up in Howard County will be a shift from where they're going now to the Hopkins hospitals in the city. We think that the case is very good, that this is a financially viable program going forward. It appears to be financially viable now with not strong margins. Obviously, it's a small program, but it does generate income as a primary PCI provider, and we think that it will certainly have even, a stronger base for viability going forward with elective PCI as well. Again, the quality of the primary PCI services that it has provided were very good, and they've made the commitments to adhere to the guidance on the appropriate use of PCI that we've also included as a standard for elective PCI programs. So we're recommending approval of adding elective PCI as part of the PCI program at Howard County General Hospital. I want to say that in most cases, you would be listening to Eileen Fleck instead of me. Eileen and her staff did the work here. Eileen was not able to be with us today, so I'm filling in for her, but I do want to give her credit for the work that she's done in reviewing this project. And joining us on the phone, I believe, in case there are any questions that I can't field, we have 4 people from Howard County General Hospital: Mr. Ryan Brown, Vice President of Operations; Dr. Peter Johnston, who chairs the Howard County General STEMI Committee; Dr. Eric Schwartz, who is the co-chair of that STEMI Committee; John Dunn, the Administrator of Diagnostic Imaging at Howard County General; and then 2 individuals from Johns Hopkins Health System, Mr. Doug Hall, Senior Director for Planning, Analytics, and Business Intelligence, and Mr. Spencer Wildonger, Director of Health Planning for Johns Hopkins Health System. So with that, I would conclude with our recommendation that we approve elective PCI at Howard County General Hospital.
Good. Very good. Thank you, Paul. Do I have a motion to approve the certificate of conformance? Howard County General Hospital established elective PCI services.
Yeah, this is Commissioner Reimer. I approve.
Motion.
This is
Commissioner
Commissioner Dorden. I second.
Second from Commissioner Dorden. Thank you. Any discussion, Commissioner? Discussion or questions? Very thorough presentation. Thank you. All in favor?
Aye.
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 Aye. Aye.
Any opposed? Looks like the ayes have it, and the motion passes. I want to thank Paul and his entire team for an outstanding, it's always a tremendous amount of work and an outstanding effort, particularly this month over the course of the multiple emergency CONs that have come through, as well as the regular workload and docket. They've stepped up and in fact sped up in the context of substantial adversity, and I think we owe them a debt of gratitude for their work. Thank you. Moving on to agenda item number 7. Redesignation of the Maryland Patient Safety Center. At our February public meeting, we received a presentation from the Maryland Patient Safety Center on their programs and accomplishments as part of their request for redesignation of the Patient Safety Center for the state of Maryland. Teresa Lee, Director of the Center for Quality Measurement and Reporting, will present the staff's recommendation regarding the redesignation request. Teresa? I hear some background noise, but I don't hear Teresa yet. Still nothing. Lavon, is she connected?
I do see her, but she hasn't put her audio pin in, so I'm assuming that she dialed in on the telephone. But I do see her connected. I would try to get her a message. We want to go to another agenda item while I try to get her connected.
We're gonna run out of things to go to.
Chairman, we have one more, Chairman Pollock.
What's that?
We have one, we have the telehealth.
Lana Sutherland. Yeah. So assessment item number 9, if we could put that up on the screen. First of all, is Alana on the phone?
Will do.
Sarah, hey.
Alana, can you speak?
This is Sarah Hawk. Can you all hear me?
Sarah Hawk, we can hear you, yes.
Okay, great.
Alana.
Okay.
Yeah, Alana, can you hear us?
She was there. She was there.
She is here. Let me just send her a note.
Okay. So we need just a quick moment.
Or Teresa, if Teresa comes up.
Alana, you're self-muted.
There we go. Is that better?
Now
Yeah.
we're good.
There you
Chairman,
go.
would you like to proceed?
All right. Alana and Sarah are here. To present on the online telehealth readiness assessment tool. The tool is designed to assist practices in determining their readiness for offering telehealth services, identify areas that need improvement, and prioritize improvement areas by importance. As a reminder, the paper version of the tool was released in 2018. RTI was competitively selected in 2019 to develop a web-based interactive version. Joining the presentation is David Sharp, Director of the Center for Health Information Technology and Innovative Care Delivery. Please proceed, ladies.
Thank you, Mr. Chairman. Good afternoon, Commissioners. So the goal of the telehealth readiness assessment tool is to provide ambulatory practices with an easy and practical way to determine their readiness for telehealth. And it does this by guiding them through self-assessment questions in key readiness areas. It provides scores to their responses associated with each readiness area, and then also presents guidance and information to improve the user's understanding of telehealth readiness. So it helps practices to understand provider, patient, caregiver, and organizational readiness with things like scheduling workflow and operational requirements. And the importance of the tool is that improving telehealth implementation outcomes and sustainability for ambulatory practices requires shifting processes that are often set up to support face-to-face encounters. So with the TRA tool, users can identify areas for improvement based on their readiness score and take steps to improve readiness by following guidance and tips that are provided, as well as informational resources. So if we go to the next slide, what staff has learned from telehealth grantees in the state is that implementing telehealth services presents challenges for practices around disruptions to workflows, appropriate use of technology, and patient involvement.
So as a reminder, Commissioners, MHCC began issuing telehealth grants to test innovative use cases back starting in 2014. Since then, the Commission has issued roughly 16 grants, and the lessons learned from each of these grants has helped to inform the work of successor grantees. The TRA tool, which you're hearing about presently, is a culmination of all things learned as it relates to the practice readiness to adopt telehealth. Alana?
Thanks, David. Yeah, so we use this information gathered from grantees and stakeholders as the basis to initiate the development of the telehealth readiness assessment tool, or the TRA tool. So as the chairman said, in January of 2018, Research Triangle International was selected through a competitive process to develop the paper version of the TRA tool, which was then published in February of 2019.
And what we heard from practices, feedback on the tool, was that it was very useful, but it was heavy, it was weighted, and that practices encouraged us to find ways to develop an interactive online version of the tool. And again, that's what we are pleased to present to you this afternoon. Alana.
Right, yes. So that work began in July of 2019 when RTI was again competitively selected to web enable the tool with the goal of making the content more interactive, engaging, and accessible for practitioners. So developing the web-enabled tool included designing the online application, considering best practices for navigation and design, conducting user testing with ambulatory practices, and then incorporating their feedback and launching and hosting the tool.
The paper version of the tool is, as I mentioned, it's heavy, if you will, about 70 pages. Taking complex content and making it easily understandable for a digital audience is a difficult task. Words alone sometimes can't make a complex topic clear and simple to understand. Feedback from users that tested the online tool have said steeply that we believe that we met the goal of taking a complex topic and distilling it down quite well. Alana.
Yes, so joining us today on the phone from RTI in North Carolina is Dr. Syra Hawk, and she'll speak a little bit more about the approach and the development process. So I will turn it over now. Dr. Hawk, I should say, is a senior health informaticist with RTI, and she oversees their telehealth research portfolio. So David, we can go to the next slide, and I'll hand it over to Syra.
Great, thank you so much. And thank you so much for the opportunity to present the tool to you today. We've done quite a bit of work on it, and we're really proud of our progress. So the next thing I'd like to talk about is the key areas of telehealth readiness. There are a number of different areas which influence readiness, and we looked to not only the experience of grantees in Maryland, but also to best practices and the state of evidence in the literature throughout the entire country when identifying the key areas of readiness. I'll go through them right now. The first one is core readiness. So that's really the extent to which a practice is even ready to consider telehealth, if they thought about what the implications are. And it's designed to give practices a sense of really what the benefits are, but also the challenges so that they have a realistic perspective and view. The next one is financial considerations. And that not only includes the costs, so costs of things such as equipment, perhaps shoring up broadband, but also in thinking about things such as how reimbursement would work, so for sustainability, and then looking at things such as if they have to make modifications to their malpractice insurance, things like that. So really practical types of considerations for finance. The third item is probably the one that has the most questions and the most associated guidance, and that is operations. And operations really covers a lot. It includes things such as workflow, scheduling, because even scheduling a telehealth visit can be very different than scheduling a face-to-face visit. And then there are unique considerations such as where will the visit take place, if the room is appropriate, so you have to think about things like lighting and glare in a different way than you do for face-to-face visits, and staffing, and kind of getting everybody on board, and also thinking about what the change management principles are that have to apply. So that's embedded throughout operations. And then the fourth is staff engagement. And staff includes not only providers, but also paraprofessionals, front desk staff, really everyone throughout the practice needs to be involved. And so staff engagement includes all of those aspects. And patient readiness is the fifth, but it's certainly not the least important. But what the literature has found and what we've seen in our previous work is that really when the other items are kind of shored up and that the staff is engaged and excited, then that really puts them in a good position to get patients engaged and to understand their patient population. So those are the 5 key areas. Thank you for going to the next slide. So, what the areas we did not change from the paper-based tool that we presented to the commission earlier, but really when turning it into a web-based tool, the idea is to make these a little bit more accessible. As David mentioned, it is a little bit heavy and it's a lot to go through. It's great information, but if we want people to do it, you have to make it easy for them. And that was really the whole crux of our approach to design and development. So the first thing that we did was to work iteratively with MHCC to design a design document. So we worked on different design principles and kind of made sure that it was in line with MHCC's colors and that sort of thing. But underpinning all of that were a few principles that you can see here. One is that it was flexible. In a paper-based tool, it's hard to go to section out of order. However, with the online tool, if a practice is really just focused on or really having trouble with a particular area, they can go to whatever area they would like first. And they can get their scoring on that and get the associated guidance and resources on that. Two is that the tool was based on best practices both for survey design and development and web survey design and development. And that really contributes to usability. We understand that people have a whole range of technological savvy and interest and experience, so we wanted to make sure it was easy for people to use and navigate throughout. The third principle is that the tool was designed and tested for a number of different types of devices. Many people don't have a computer. They might just use their iPad or phone. And some people only want to use a computer. They don't prefer to look at things on a phone. It might be too small. So this is optimized regardless of what the device is. And finally, while we are looking at a telehealth assessment tool, some folks may not be ready or willing to look at the tool online, or they might wish to have a paper version later. So there is the ability to print out the tool or download it if people prefer to do it that way. So that way, regardless of what practices prefer, they can access the tool and the associated guidance. So once we designed it, we completed user testing with a variety of practices and made some modifications based on their feedback, and then we launched the tool. And so I think now we can go to the demo. Now you can see what it looks like, and it's easy to use. You can see here there's a little bit of information about it, about MHCC, and you can launch, if people want to read that, they can read it and then launch, or if they are impatient, they could have launched it from the top. So regardless of how people prefer to navigate, there's options for them. If you could please launch the tool for me. And here you can see these are the areas that I just went through, numbered 1 through 5, and they can complete it in any order that they would like. We were intentional in the order that we selected. However, it does not necessarily make a difference for a practice, and so we want people to feel like they can focus and start in on the areas that are most relevant for them. Also, they may need some help. It might not be that one person can complete all 5, and that's fine too. And so, David, if you wouldn't mind just selecting one, you can pick whichever one you'd like. Let's start. So people will pick one, and then you can see that within each concept, there are or each component, there are subcomponents. So for core readiness, there's the need for telehealth and organizational leadership buy-in. Those are the two sub-concepts. And then the options are for people to either answer the question or they can view guidance. And so when they answer the questions, this will take them through questions one at a time, so it's easy to read. And they just go through each question. And then at the end, they will get an assessment of how they're doing. And then they can go ahead and read the guidance to get a little bit more information. And the guidance is the same regardless of what the scoring looks like. So if they did great, the guidance is the same as if maybe they're just kind of starting to think about it. And that was also intentional because there are a lot of different components, and we want to make sure that everyone has the resources they need. So that is, and this is the guidance. And so I recognize it's a lot to look at on the screen, which is one reason that people can look at it this way, or they can download a PDF, or they can print. And all of the guidance has a little bit of a summary, then some actions to take. So here you can see they're looking at, what kinds of services would they offer, what the benefits would be. And then each guidance has a pretty hefty reference section. The audience for this is providers and their office managers, and they are pretty evidence-driven. So while we don't expect them to look at the evidence, we have found, and the user testing actually demonstrated that folks took comfort in knowing that this was an evidence-based tool and knowing that they could go to the references if they wanted to. And so you can see these are the 5. It's organized the same way for each one. David, if you wouldn't mind just scrolling all the way to the top. You can see at the top here, at any point, people can go to their results. They can go back to the concept menu, which was the first one. They can go to the resources, and then the paper tool. So there's all kinds of things that people can do. So if they're in the middle of it and they're thinking, I kind of just want to go back and look at the finance, they can do that. These are resources that are organized into different categories. So if people want to learn a little bit more, if users feel like they'd like to have some general resources, privacy and security, looking at evaluation and that sort of thing. You can scroll back up. And then the paper tool. So if people prefer, the paper tool is available as a PDF that they can print, they can save, they can email. And this is the same that we presented to the commission previously. There have not been changes made to that. And then I think that might be it. David, if there's something else that you'd like to show, please go ahead and click on it. Otherwise, I'd be happy to take questions.
You might just take one moment and talk about the scoring. So let's just see if because there's
sure.
Scores.
I think.
Let's see, answer question. You might explain how the useful the tracking of progress works.
Sure. So, as you go along, you can see here there's a way to track progress, question 1 of 4. And David, maybe you could just go ahead and answer, and then just hit next, and David is not making a statement on how he feels about telehealth, of course. He's a wonderful champion, but putting in 4, then it kind of auto takes you to the next one. But because you don't get a subcomponent score, there's only a few questions, you get a score for the whole entire component. And so you can see here that there's a variety of different topics and a variety of different areas. And then, David, if you want to click on My Results, that way you don't have to do the whole entire thing. So then, of course, you can see that David hasn't answered all the questions, so it's an area of an improvement. But on the side, you can see that for each of the subcomponents, there's individual kind of scores. And we didn't want to give people numeric scores because this is not designed to be punitive or an assessment like that. What it's really designed to do is to get folks thinking, practices and or their office managers or providers, about how much have we thought about these important areas of telehealth, and what could we do? So if you're thinking, oh gosh, I'm almost ready for assessment approach, they can go to that guidance, take a look, and then the guidance will give them some actions to go through. And so when you look at maybe the coloring and the bars and all that sort of thing, it's all designed to get folks thinking about what kinds of progress has been made to date and what has to happen next. Because it's really important that not only do we provide practices the resources that they need to have a successful telehealth implementation, but that we provide a realistic view and a realistic look. If people implement or they're not quite ready or they haven't taken the steps, then that can really sour a practice on telehealth for the duration. And of course, now more than ever, so many people are trying to implement really fast. So having a resource like this is invaluable in getting folks up and running quickly. And then later on, when things settle down and we don't have all of the supports and loosening of regulations and barriers that we have now, then people can go back to the tool and then look again and kind of adjust their implementations as needed.
So I think, Mr. Chairman, Commissioners, that takes us to the end, but I would note that the tool went live on March the 24th. We've had since then 464 users and 572 sessions. So we've not done a whole lot to promote it, and you can see it's getting traction. We also discovered beginning of last week that the AMA was putting a link to this tool in some of their telehealth educational materials. So it's getting traction without us doing a great deal of work to promote it. As Ben mentioned early on, we're planning to do some work with telehealth expansion efforts, and this tool will be key to helping us help practices assess their readiness to implement telehealth and to be successful with it. Because one of the key drivers all along has been it's not just a technology initiative. It requires supporting policy and engagement from staff and clinicians to really make this work. So, Mr. Chairman, that concludes our presentation. We're happy to answer any questions.
Thank you, David. Are there any questions from any of the commissioners?
This is Commissioner Boyer. I have a question. Are there any plans to do public education to alleviate trepidation or fear of, and based on my own family and my older aunts using it for the first time, they were very skeptical about it, but in the alternative of going to the office was not doable. But once they did it, they loved it. But like I said, there's a lot of trepidation for it. So is there any plans to do community or patient education, maybe even targeted to certain patient populations within a practice?
Sure, that's a great question. Thank you. We are starting first with the practices to help train them best on how to educate and engage their consumers. And this tool is really helpful to get us a picture of where they are so we can identify what type of resources they may need in order to become better at engaging patients. Because what we have learned from the grants going back to 2014 is that without really good patient education, it creates a situation, as you've sort of alluded to, and it can often cause consumers not to want to re-engage with telehealth. So we want to try to take those lessons learned and ensure that it's not the case. We also think between this first phase of COVID and the second phase, where we have opportunities to engage consumers more directly, we can do a bit more community outreach to try to make sure consumers are understanding the value and feel comfortable in using it. So when we can re-engage directly with the community, we are absolutely planning to do some of that work.
And this is Syra Hawk. If I could just add one thing about the tool itself. So one of the pieces about patient engagement does involve patient education from the practice. And the literature has shown that the single most factor that influences patient satisfaction and willingness to use telehealth is if they hear about it from their doctor. If people tend to trust, if their own physician says, you know, this is something that will be helpful to you, and if they explain it, that's the single most predictor. And it's been shown to actually be more effective than generalized educational programs.
Mr. Chairman, this is Dr. Bhandari. So this telehealth is not going to be only the physicians, those who have established relationship with the patient. It could be any physician. If I'm not wrong, I think that's a correct statement. For example, it's not only the patients who I have built a relationship over the years. Anybody from out of state also can do telemedicine, whether they have seen a patient physically, even single time or not.
Commissioner, your point is a good one. During this COVID crisis, the Hogan administration, Governor Hogan, has issued a series of executive orders and particularly around relaxations around use of telehealth. And one of the executive orders allows for expanded use around licensing of practitioners who are out of state or in state using telehealth for different circumstances under certain situations. It is
That is true. It's only for 3 months because I'm still chairing the Board of Physicians. So well aware of that. But eventually, the COVID-19 pandemic is some very unusual circumstances. But after that ongoing basis, there could be some issues which we have, which I, see there may be some for upcoming challenging with for the patients, the best care and the safety.
Yeah, I think beyond the tool itself, there are those kinds of policy questions that need to be addressed on the other side of this epidemic.
Thank you so much.
One question for Commissioner Pollack. One question for the folks from RTI. Certainly one of the strengths of the organization is your work in evaluation. Have you anything about how you could evaluate the impact of this product on the use of uptake of telehealth in the Maryland physician and health professional community?
We would be delighted to work on that with you. But yes, I thought about a couple of different things that would be interesting to evaluate. One is looking, of course, at uptake, but I also think that we should look at uptake across different types of providers, so primary care versus specialty care across the state. And then really, while the audience for this was independently owned physician practices, there might be some federally qualified health centers and places like that that would be interested. And then when, after looking at this, it would be interesting to do a process evaluation of people who have used the tool to understand if it was helpful to them, and then also to take a look at what their telehealth implementations were. And if we really had some access to data, we could even add in some quantitative components such as cost, quality, and outcomes. So there are a lot of different things that we could look at, both for the tool itself, but then also for telehealth uptake generally.
Great. One second question, Dr. Pollack, if I.
Yes, please, Ben.
The FCC has, through the CARES Act, has a significant amount of money set aside for diffusion of telehealth. Do you have any suggestions on areas that the MHCC, working with the eligible provider community, could take on?
Your question is directed
at RTI.
Oh, I'm sorry. I thought it was, I didn't realize it was directed at me. Yes, I have a couple of different suggestions. One is the FCC grants are largely designed to shore up capacity for rural areas and for areas that are underserved. And Maryland, of course, is characterized by world-class and urban care in urban settings, and then perhaps a dearth of providers in some of the rural areas. So I think it would be interesting to look at some of the effects on disparities. And also, one of the new areas that's emerging is provider-to-provider communication and provider-to-provider things such as education that also includes second opinions and e-consultations. And I think particularly for Maryland, where you have some of these disparities, it would be interesting to expand to some of those areas. And then lastly, something that I think would be good to look at, and I know you've started a little bit, is looking across different care settings. So long-term and post-acute care is one, and then home health, particularly with some of the relaxation of rules by CMS around where the patient needs to be located. I think that would be a really emerging area, particularly with the aging of the population.
Thank you. And David and I and others on the team will be meeting with Secretary Kramer on the Department of Aging to talk about how the Healthcare Commission could play a role in expanding the Department of Aging's home-based care initiative. And my thought is that expanding use of telehealth beyond professionals is an opportunity given the crisis that could really provide access to older people who are isolated and increasingly isolated in the situations we face today.
Yes, and especially right now, where people who are isolated have even less interaction in person than they do normally, then this would really be very helpful.
Thank you.
Thank you.
Thank you very much. At this point, do we have Teresa on the phone?
I'm here. Can you hear me?
We can hear you.
Hello?
Welcome back,
okay.
Teresa. Yeah.
Thank you.
So
Thank you.
just to reintroduce quickly, during our February public meeting, we had a presentation from MPSC regarding their programs and accomplishments as part of their request for redesignation as the Patient Safety Center for the state. Teresa Lee will present the staff's recommendation regarding the redesignation request.
Thank you, Chairman Pollack, and good afternoon, Commissioners. Thank you, Chairman Pollack, and good afternoon, Commissioners. You can hear me, right?
We can hear you. Good afternoon. Yes.
Okay, good. Okay. First, I'd like to provide a brief background on this recommendation, particularly for our new Commissioner, Dr. Bhandari, and as a reminder for other Commissioners. A memo summarizing this recommendation was also included in your packet. Maryland state law authorizes the MHCC to designate for a 5-year period a patient safety center to develop, coordinate, and implement patient safety initiatives across the state. In 2009, the Commission designated MPSC, Inc. for a 5-year period and redesignated them in 2014 for another 5-year period. The current designation ends the end of April, in this month. Last December, the Commission published an RFI, a request for expressions of interest, to determine if there were other organizations interested in this designation. The RFI specified that the designated PSC would align its programs with state priorities, including the objectives of the total cost of care model, the Health Department's Diabetes Action Plan, and we emphasized the need to reach out to and engage non-hospital providers. It's important to note that there is no guaranteed funding. The MHCC does not fund the Maryland Patient Safety Center. The HSCRC has provided a limited amount of funding through hospital rates historically. There is no guarantee at this point that that will continue. We received one response to the RFI, and that was from the incumbent. A copy of their response is included in your packet on our February meeting, and representatives from the Maryland Patient Safety Center presented an overview of programs and accomplishments at that time. As a final step before developing this recommendation for your consideration, the Executive Director and staff met with representatives from the Health Department, OHCQ, HSCRC, and the Maryland Patient Safety Center to get input on how to move forward and to reach consensus on priorities. There was agreement on the value of a state-designated entity to coordinate patient safety activities and general consensus on priorities for the upcoming year, and most importantly, a willingness to work together. I won't review all of the priorities, but just to name a few, the diabetes program is of course important. Disparities in care and implicit bias is a major focus that we would like the Patient Safety Center to undertake if in fact they are redesignated. And ED performance and delays in care and diagnosis is another, just to name a few of those that we discussed during that interagency meeting. So our recommendation is that the Commission redesignate the Maryland Patient Safety Center for another 5-year period. And if you approve this recommendation, the staff will work more closely with the Maryland Patient Safety Center as well as with our sister agencies to promote the activities of the center. We will also identify measurable objectives to monitor ongoing performance and update the Commission semi-annually. As in the past, Either a member of the commission or commission staff will serve on the board. And finally, the executive director and the Maryland Patient Safety Center will enter into a new MOU to specify our expectations going forward. That concludes my staff recommendation. If you have any questions, I'd be happy to take those.
Thanks, Teresa. Do I have a motion to redesignate MPSC Inc. as the Maryland Patient Safety Center?
So moved. O'Grady.
Is there a second?
Second, Boyle.
So moved by O'Grady, second by Boyle. Discussion, commissioners.
This is O'Grady. I have one question. Tressa, in terms of just your judgment on this, it says that there's going to be one member, either a commissioner or a staff member, that would sit on their board. Now, just my experience at the federal level would tell me that there's some trade-offs there, that the staff member will be more expertise, but that commissioner might have more weight. And I didn't know what your feeling on that one was, given this, the trade-offs and kind of what we're trying to accomplish.
Well, in the past, Commissioner Fonstein was designated the board member, but of course he left, and we didn't immediately follow up with a replacement. But I think Ben has some views on this. I don't know whether your preference is, Ben, for a staff person for certain reasons, or the designation of a commissioner.
So my preference is it says one, it doesn't say limited to one, that I think we try to have both. I think that a staff member being ongoingly engaged with the patient center would be beneficial, and I think as well a commissioner to garner additional impact and credibility would be beneficial. We have not spoken extensively with Dr. Eig about this, but I think it is reasonable that we would have to expect that we would have more than one representative, perhaps one in ex officio capacity, so the would not be dominated by MHCC. But I think what we've learned from our experience with CRISP, where David, at least one member of his staff, and I attend all of their board meetings, that we can offer different perspectives and different information to the other board members on the directions that the MHCC thinks CRISP should go. And I think it's helpful in that regard. And that would be my approach, Commissioner O'Grady.
Sounds good. Thank you.
And I should say that Barbara Epke, the interim president, we've discussed that a bit, and they're open to what our requirements and desires are. So
I had the same conversation with Dr. Heyer, and I think I agree. They would. So I think that's the two would be better in this situation, particularly given the challenges with that relationship that we've had over the past, I'd say, 5-10 years. The other questions?
Chairman, this is Chip Dorden. I was just curious, just as an education, is there a financial component to this? I mean, is it that this is within our budget? There's nothing that talks about any kind of money, and I'm always concerned about that when you only have one applicant, so to speak. But is that, I don't need to know the details, but is that all under control?
So
yes,
go ahead.
The Patient Safety Center's budget is about $1.7 million. Close to $400,000 comes from the HSCRC through hospital rates, and that's an amount that has decreased over time because the idea was that they would become more self-sufficient. the largest part of their budget is from membership dues. So, and that's why I mentioned earlier that because we received one respondent, I believe that's in part because there is no guaranteed funding to support this. The Maryland Patient Safety Center will try to continue to do this work even if they weren't designated, but the designation provides more credibility, particularly as they go beyond the hospital setting to the other provider types. And they're also working to see if, in fact, they can get grant funding, and they're in having conversations with HSCRC going forward. But it's just there's no guaranteed funding at this point.
I know the HSCRC at this point has not been excited about renewing that $400,000. I think that might be a wild understatement.
Right.
Ben, is there any update on that?
I don't think that has changed, but I think with progress, HSCRC might change their perspective.
Thank you. All right.
I think, never mind.
Go ahead, Teresa.
No, I was going to say there have been some additional discussions, I think, about programs that the Maryland Patient Safety Center can undertake that the HSCRC would like some help with. So that may change over time. And I should also say that Barbara Epke, the interim president, is available on the line, but I don't think, if you wanted to talk about this a little more, but I think you have a general sense of where we are.
Yes. Are there additional questions? Hearing none, we have a motion and a second. All in favor?
Aye.
Aye. Aye.
Aye.
Aye.
Any opposed? All right, hearing none. The certificate, the redesignation of the Maryland Patient Safety Center is hereby approved.
Thank you.
Last thing on the agenda then for today. Thank you, Teresa. The last thing on the agenda then for today will be an overview of upcoming activities. Ben, would you like to share with the commission?
So thank you, Dr. Pollack. First off, I want to thank you and your colleagues today for attending this virtual meeting. It does get better, but we know there are some challenges, particularly given the amount of throughput on the internet today, but we'll look at improving that going forward. I want to recognize particularly LaVon Ward, who not only did a splendid job today in getting this working in spite of some challenges at various places along the line, but LaVon really monitors the system on a daily basis, and he's the only one that I've judged, given the governor's executive orders, as essential to be in the building. So he is not only keeping the IT systems going, but also serving as the overseer of the operation, as it increasingly is focused strictly on the IT activities. I also wanted to call out a couple of the centers, particularly David Sharp's team, who's been working on this telehealth effort, not quite as visibly as you've seen from our planning staff, but I think very importantly, last Friday, I called on David to try to figure out how we could collaborate with the Council of Governments in DC, and by Monday, he had a proposal ready that we could carry forward within the state of Maryland. So there's getting things done quickly is part of that team's DNA. I don't want to forget about our ECON activities, and that's something that Sue Ellen Weidman and I have largely taken the lead on. And we have committed to the applicants to turn these around in 24 hours or less. That means short-circuiting the normal review processes. But given the activities that we are to conduct and the challenges we face, I think that's one that we've met. We've also guided other state colleagues in how to license new types of facilities, such as the convention center, and hopefully that will be up in operation shortly. We operate almost a 24/7 operation. The best example I have is with Kaiser, where we heard about it on a Friday, and by Monday we had those 4 facilities up and ready to be designated as emergency sites. So I want to thank Sue Ellen in particular for being accessible, certainly 24/7. And something area you haven't yet heard much about is the work that Ken and his team are doing in terms of trying to use our APCD data to identify areas where there are particular risks. Nothing formal to report, but we're working with some DC data as well as CRC colleagues to see if the information, the historic information, can be a guide to identifying hotspots going forward. So I want to thank those people in particular, but really all of the staff and their ability to work virtually. We pride ourselves in anticipating that this would happen, and I can say that from almost the first day, everyone was able to pitch in and work virtually and accomplish what they needed to do, either their assignments or the new responsibilities as a result of the pandemic. I think the agenda for May is still a little uncertain. We'll have Ken talking about spending for the privately insured and spending on primary care, but I'll also ask them to talk about to the commission how the APCD, which is a significant investment, can be really redirected to focusing and providing information on the pandemic. Several CONs will likely be on the docket, as well as emergency CONs, which, as I said at the outset, I think they've slowed down a lot, but we could see a resurgence, especially with skilled nursing facilities. And we'll discuss with the chair whether we need to have a interim meeting mid-month to clear those emergency CONs through your confirmation process and move forward. Lots of ideas that are going to cause discussions. Certainly, we're very excited about the role that Commissioner Thomas is going to play. I would only note, I think this is extremely important, that mortality rates among the under 60 in the United States are much, much higher than here than they are in other parts of the world. And it's thought by some that these are largely due to disparities in access to healthcare among populations of color and lower income individuals who typically have less access to insurance. We need to use our information and our expertise to drill down further in that. I know Commissioner Boyle and Commissioner Boyer have both raised this question about what we do to look forward to anticipate what we do need to do next. And I think we should all say that what we learn should prepare ourselves so that the commission in a small way makes certain that this pandemic never happens again. In a small way, we can contribute to that very high goal. Certainly, challenges like the outbursts in nursing are things we need to look at very carefully, and we'll be working with others and bring back ideas to you to identify how we can deal with those high-risk areas, which are really ground zero in the spread of the pandemic over the next several months. We'll also, I think, begin in May, begin to outline our plan for reopening. There may be nothing formal in the standpoint of the state, but clearly the idea of state-by-state reopening is something that how fast you do it is not in debate, but the fact that you would have some sort of staggered reopening, I think, is an agreed upon strategy. We'll be talking about that internally as we think about that for ourselves as well. And then finally, I will have a report to you on what the financial implications are of the pandemic for our budget. Certainly, we expect to make some reductions and adjustments. We hope to do that prudently and strategically with in collaboration with the other agencies in the state government. So there's a lot of things that I tentatively will be bringing to you. We'll just need to talk with the chair to move forward on that in a planned way. Thankfully, it's a 5-week between this meeting and the meeting on the 21st of May.
And Ben, can you hear me?
Yeah. Yes.
I was just going to remind you about Mariama Gondo and the work that was done to develop that online SurveyMonkey tool for the freestanding ambulatory surgery facilities to see what their capability would be to actually support the hospitals during this pandemic. That was a quick turnaround.
Information, and although that was useful information and it actually highlighted challenges of going forward in Maryland with the use of ASCs as alternative site care. Good point. Thanks, Teresa.
Thanks, everyone. Thank you, Ben. Any questions for Ben? Hearing none, I'll entertain a motion to adjourn.
So moved.
Second.
Seconded.
Any opposed? Thanks, everyone. Stay safe.
Thank you.
Thank you.
Thank you.
Bye-bye.